We are live.
Good evening and welcome everyone to the DOS Postgraduate Education Program. As you all know, the Delhi Ophthalmological Society has come up with this innovative program that intends to focus on the teaching of postgraduates all across our country, both postgraduates as well as DNB students. So today we are happy to say that we are here on the education program. As you all know, the Delhi Ophthalmological Society has come up with this Okay, so there was some sound disturbance. Sorry for that. So we are here today on the sixth lecture of our. Can you see the screen?
Yeah, it is visible.
So we are on the sixth lecture of our postgraduate program, wherein we are doing with the oculoplasty series as of now. And today we have with our panelist, Dr. Puneet Jain, sir, who is also the course coordinator. He's a consultant of the oculoplasty department at the Sharpsight Eye Hospital. And he's done his MBBS from Maulana Azad Medical College and post-graduation from the prestigious RP Center for Ophthalmic Sciences. The speaker for today is Dr. Sahil Agrawal, and he's going to talk about the topic lid reconstruction, which is a very important topic, both as a long question, as well as whenever you're dealing with any long case of a lid tumor. Lid reconstruction is a question that is often asked about. So Dr. Sahil Agrawal is currently working as an assistant professor in the oculoplasty department at RP Center, AIMS, New Delhi. He's done his residency and subspecialty training from the same organization. His area of interest is eyelid disease and periocular aesthetics. He has over 60 PubMed articles and is a peer reviewer in various PubMed index journals, mostly pertaining to oculoplasty. He is currently an assistant editor at the IGO, DGO, and subspecialty editor at the IJOOP and editor at the IJCR. So with this, I would like to hand over to you, Dr. Sahil, for this interesting lecture that we'll have on lid reconstructions. I hope all the students are going to gain a lot. And if you have any questions, you can put in your questions in the YouTube channel as well as on the platform that we are working on. Over to you, Sahil.
Right. Thank you so much, ma'am, for such a kind introduction. And a very good evening to everyone. Are my slides visible?
Yes.
So
You can
I
just
hope it's a
move full
slideshow
screen.
mode.
Yeah, it's full screen. It's visible. You can move.
Right. So I'm grateful to DOS, the entire team of Delhi Ophthalmic Society, Dr. Pranita ma'am, Dr. Punit sir, and Dr. Pallavi for having me here to present this lecture on lid reconstruction. The eyelids are the most mobile tissues containing which acts as a shutter to protect the eyes by spreading the tear film over the cornea and conjunctiva. Besides its functional importance, it also contributes very well to the aesthetics of the face, providing the facial features of an individual. So these are few of the pre-op and post-op patients that we recently operated. If you look at the pre-op photos, that might appear to you quite complex, but trust me, it is all about unscrambling this puzzle. But how to do that? Basically, you need to know the surgical anatomy very well. Besides that, you should know when to do, what to do, and how to do. So let's start with surgical anatomy. For all practical purposes, the eyelid is made up of two lamellas, the anterolamellar and the posterolamellar. Anterolamellar comprises of the skin and the orbicularis muscle, and the posterolamellar comprises of the tarsus and the conjunctiva. The eyelid margin is about 2 mm in width. Basically, it is divided into two halves at the gray line, which is an isolated section of pretarsal orbicularis muscle, just anterior to the tarsus. It serves as a dissection guide to split the eyelid into the two lamellas, anterior and posterior. The eyelid margin can also be divided into two halves along the length of it. The part containing the cilia is the pars ciliaris, and that about the puncta near to the middle canthus is the pars lacrimalis. Besides this, one important structure in both the upper eyelid and lower eyelid is the tarsal plate. It is the cytoskeleton of the eyelid, helps in providing the rigid taut structure and the shape that the upper eyelid and the lower eyelid has. We have the lateral canthal ligament, which is inserted onto the Wittnall's tubercle laterally. So we need to know that the Wittnall's tubercle is behind, posterior to the lateral orbital rim. So whenever we are reconstructing the lateral canthal damages, care should be taken that we go behind the posterior orbital rim to near about the Wittnall's tubercle, and the middle canthal ligament is attached to the anterior and posterior lacrimal crest. So the post-operative outcome should have a horizontal palpebral aperture of about 28 to 30 mm in length, palpebral aperture height of about 9 to 10 mm. Also, the lateral canthal angle is 2 to 3 mm higher than the middle canthal angle, which is more curved than the middle canthus. And that the middle canthus lies at about around 15 mm from the midline. However, all of this comes only into role when the other eye as well is involved. What you need to achieve is symmetry. So whatever, however the other eye is placed, this is what you have to achieve. That's all plasty is about, symmetry. To have a good alignment of tissues, skin to skin, orbicularis to orbicularis, tarsus to tarsus, and conjunctiva to conjunctiva, there are subtle anatomical landmarks on the lid margin which help as a guide to provide good alienation of the tissues together. So for the posterior lamella, it is the meibomian orifice, and for the anterior lamella, it is the space between the gray line and the cilia. So sutures pass through the meibomian orifice and coming out to the other cut edge of the meibomian orifices would help in aligning the posterior lamella together, and switches pass through this area between the gray zone and the cilia will help in aligning the anterior lamella together, and this would eventually result in better tissue opposition of skin to skin, muscle to muscle, and conjunctiva to conjunctiva. Also, as far as face is concerned, the scars are very much important. The scar should be as conspicuous as it should be. First thing, you have the lid crease in the upper eyelid. So whatever incisions you want to place, you can place along the lid crease, so that would remain hidden. Besides this, all the skin incisions in the face should be along the resting skin tension lines. So what are resting skin tension lines? These are basically wrinkles in the skins which happen perpendicular to the action of the underlying muscle. So for example, this is the orbicularis, which is all around the eyelid. So orbicularis role is to close the eyelid. So the action is vertically down. So the wrinkles, the lines would be perpendicular to this action, that is horizontally. And that is what you see in this figure, that the lines are placed horizontally all around the eye. The scar should be along the and parallel to these lines. This would result in a very less scar formation, not a very good scar formation, eventually a cosmetic rehabilitation, as well as that wound tension would be least. Besides it, we can never forget the vascular arcade that supplies the eyelid. It is basically the marginal arcade and the peripheral arcade. The marginal arcade is present about 2 mm away from the lid margin, both the upper lid and the lower lid. The peripheral arcade is above rests above the tarsus on the upper edge of tarsus. So in the upper eyelid, it is about 10 mm in height, and in the lower eyelid, it is about 5 mm away from the lid margin. These are formed by the middle palpebral arteries, which is in turn supplied by the angular artery medially and by the lateral palpebral artery laterally. So the arcade is very important, especially in cases where we need to do flaps and grafts. So any compromise of the arcade on both sides, on the arteries on both sides, would lead to necrosis and eventually a failure of whatever procedure you have done. So you should be very careful about dissecting and leaving behind the major arteries intact. So, after knowing all of this surgical anatomy, let's focus and see when are the conditions, what are the conditions where we need to do lid reconstruction. So, it could be congenital or acquired. And congenital, we have the full thickness colomas, which could either be isolated or they can be associated with these three syndromes. I think everyone should be knowing about all the components of these three syndromes as the examiners tends to ask about them. A golden hour syndrome, a Tricho-Collins syndrome, and Fraser syndrome. Besides them, you can also have acquired causes, the most common ones being post-surgical resection of tumor, iatrogenic that we create intra-op, as well as post-traumatic patients. Besides that, at times you can have burns patients coming to you, irradiation patients coming to you, and then it could also be following a previously complicated surgery. So with lid reconstruction, what do we aim? We aim to achieve an adequate eyelid function so as to form a good physical barrier for the globe, which prevents any micro traumas to the cornea and the structures within. But apart from that, apart from the functional aspect, what is also important is the acceptable aesthetic result. How to achieve them? So the goals being anteriorly, we should be able to replace the skin and muscle lamina, and posteriorly, we should be able to replace a cartilaginous framework in place of the tarsus with a smooth mucous membrane lining posteriorly in place of the conjunctiva. So for the posterior lamina, you can either take a mucous membrane graft from the oral areas or a nasal pericondylar graft. So these are the commoner ones that we tend to use. We should always take care whenever required. Both the lateral and middle canthus reconstructions is done. Very importantly, both the lamina cannot have two free grafts. So you can either have an anterior lamella with a flap, a myocutaneous advancement flap, with the posterior lamella being formed by the mucous membrane graft. So you have a flap and a graft. Or it could be either way around, that the anterior lamella has a skin graft, a full thickness skin graft, and for the posterior lamella, you have the sliding tarsal conjunctival flap. So if both the lamellas have free grafts, there are high chances of necrosis in view of poor blood supply the bed would have. We should also ensure that the wound margins are everted and there is undue wound tension at the closer side. So with wound margins everted, what I would especially mean is in cases of lid margin areas where you need to keep this wound margin everted, because eventually there would be some fibrosis and this everted wound margin would come in level of the rest of the lid. If at all there was no pouting of this lid margin area, this would have resulted in a notch or a coloboma formation, a shallow coloboma formation, which would otherwise again be non-cosmetic and you need to do another surgery for that. So always keep in mind, everted wound margins are good, especially at the eyelid margin. Coming to pre-op evaluation, you need to see whether it is a defect in the upper lid or the lower lid. Is it full thickness defect? Is it just the anterior lamella which is defective? What is the size of the defect? Is it less than one third to half to two-third, or more than that along the horizontal palpebral aperture? Whether the patient has, how old is the patient? Especially in elderly patients, you have a lot of laxity in the tissues. So what you can do is you can easily get away with a smaller surgery rather than doing larger surgeries like Hughes or cutler bed lid sharing surgeries, or even greater flaps like glabular flaps or a rotation myocutinous flap. We should always take into account again whether there is a middle lateral canthal injury, and if at all there is a middle canthal injury, we should look into the lacrimal system, especially the canalicular part, which might always be involved, and repair them at the earliest. So now how to reconstruct? As I said, a lid defect could be either a full thickness margin involving one or an only a partial thickness one having the interlamellar defect. So it could either be a primary lid closure with or without undermining, uh, a closure with left to heal by secondary intention, also called as laissez-faire, of a skin graft, which could be a full thickness skin graft or a partial thickness skin graft. And there are a variety of flaps. For these flaps, you can always remember this mnemonic of star I. Star S sliding, T for transposition, A for advancement, R for rotational, and then I is for island flaps. Coming to full thickness flap, we'll start with that. So if the defect along the horizontal length of the lid is less than one third, or if it's one third to half, or if it's more than half to two third. So for defects which are less than one third, we either do a direct closure. If a direct closure is not possible and the wound is still under tension, you can add to it a canthotomy, a lateral canthotomy. Even if then it is still under tension, you can also do a cantholysis of one of the crux. So a direct closure with or without canthotomy and a cantholysis. Secondly, we have for defects which are one third to half in size. For in such defects, we have the tensile semicircular rotational flap. And for larger defects, we have two different surgeries for both upper lid and lower lid. For the upper lid, we have the conventional cutler bed technique. And for the lower lid, we have the conventional Hughes tarsoconjunctival flap, in which it is just the posterior lamella which is reconstructed. We need to put in a skin graft or an advancement flap for reconstructing the anterior lamella. However, for the theoretical purposes, you may also remember a reverse Hughes technique for the upper lid defect, a Mastardis lid switch, and a myocutinous advancement flap. And for the lower lid defects, you can still remember the reverse cutler bed and the Mastardis myocutinous rotational flap. So starting with less than one third smaller defects, when you have a smaller defect, especially which is also shallow, so what would happen is if you are attempting to close them directly, bring the edges close together, the tarsus there would buckle on each other. Once the tarsus starts buckling, you'll have a posterior ill-formed lamella and a defective functional element of the lid. So basically, what you need to do whenever you have a shallow coloboma and a small defect, you need to convert first this into a pentagon. So how is the pentagon done? Basically, the two limbs correspond to the height of the tarsus, and then you have a inverted V, the apex of which corresponds to the fornicis posteriorly. So you take off entire amount of it, and then you'll be left out with this perpendicular defects, and then you close them using a vertical mattress. I'll show you how a vertical mattress is done. Just consider that this is the anterior lamellae and this is the posterior lamellae. Again, this is the anterior lamellae of the other cut edge and this is the posterior lamellae of the other cut edge. Right. So we start at a distance. I'll show you for the anterior lamellae. We start at a distance of about 3 mm away from the lid margin, the cut edge margin. Go at a depth of around 3 mm. Cross over the defect size. Also go along 3 mm and 3 mm out. So basically, this much area, this distance is 3 mm on both sides, and the depth of it is also about 3 mm. Once that is done, we then come back at a distance about 1 mm now from the lid margin, from this defective area. So this is again the needle coming back, go to a depth of 1 mm, come out from the other side across at a distance and a depth of around 1 mm. So again here, this distance is 1 mm on both sides, and this defect depth is about 1 mm, and then tie them. So this leads to a proper apposition of both the anterior and posterior lamella. As I said previously, for the posterior lamella, you'll go through the meibomian orifices, and for the anterior lamella, the area between the cilia and the gray zone. So this would lead to a proper apposition of all the elements together. Once that is done, you need to close the anterior lamella. Now the tarsus to tarsus and conjunctiva to conjunctiva and muscle to muscle can be closed using a 6-0 vicral suture here. And then the skin is closed again with interrupted 6-0 silk. So this is one patient of full thickness upper lid laceration with a margin involvement, wherein you can see the aesthetic outcome. We have very least amount of scar. This was about at 6 months follow-up. So now the case condition comes where you have it, where you want to do a direct closure, but it's still under wound tension. So what you need to do, add to it is a canthotomy. So what is a canthotomy? The lateral canthus is I'll show it here. The lateral canthus is basically a Y-shaped structure. So a canthotomy means basically cutting, opening the lateral canthus. So basically you first use a artery forceps to basically devascularize the lateral canthus, clamp it there like we are doing it here. We are clamping at the lateral canthus, devascularizing it so that it doesn't bleed much. And then using a tenotomy forceps, tenotomy scissors, we cut open this. So this gets converted into a V-shaped thing. So now the tissues are more mobile, and then this can be brought inferiorly towards the lid defect so as to have a good closure. Even now, if the lid defect is not getting closed very well and the wound still appears to be under tension, it is not an advice to keep the wound under too much under tension, because it might give away. So what you can do now is you can basically divide the crux. So this is the upper crux and this is the lower crux of the canthal tendon. So you can give a cut here if it's for the lower lid, or a cut here if you want to mobilize it for the upper lid. Once you give this cut, you have enough tissue now to mobilize towards the lid defect, and that can be closed very well. Care should be taken that it also repair the lateral canthal area now. So a direct closure, not possible. Add a canthotomy, not possible. Add a cantholysis. I'll show you the video in a while. So for defects 1/3 to half, we have the classical Tenzel's semicircular rotational flap. I believe this is a very important flap that every person, every ophthalmologist should know, because especially in elderly patients where you have large defects because of some tumor resections, this comes very handy, because elderly patients, as I said, would have a lot of laxity of tissues, and this we can get away with a smaller single stage semicircular flap rather than doing a two-stage surgery, the Cutler bed and the Hughes technique, wherein you have a lid sharing procedure, and that has to be taken care of after 6 weeks or so. You can just get away with a single stage surgery. It is again very important in the childhood age, because you would not want any child to be having a palpebral aperture which is closed, leading to amblyopia, which is the lid sharing procedures, Cutler bed and Hughes. Rather, wherever possible, a tensor should be tried. But again, keeping in mind, the wound should never be under tension, because it will give away and eventually you'll have to redo everything. So this is a video on Tenzel's semicircular flap. It was a 6 months old child with a full thickness coloma of the upper lid. After having measured the defect size, the incision is marked starting from the lateral canthal area in a semi-rotational fashion. The lateralmost end should not go beyond the eyebrow, lateral part of the eyebrow, because beyond this you have the facial nerve branches, so that might get knocked off. Post that, using a 15 number plate, the skin was incised, and now canthotomy is performed. A lateral canthotomy is performed so that the lateral canthal opens up, and myocutaneous flap is raised here. This part, the myocutaneous, the skin and the underlying muscle is raised, and that is brought close together to the other side of defect. The edges are brought close together by suturing the conjunctiva to conjunctiva and the muscle to muscle using a 6-0 vicryl. So once you have the tissues brought close together, you close the remaining part of the lid defect using a vertical mattress. So you started away from the lid margin, went to a good depth of around 3 mm, again exiting on the other side far away. So it is far, far, near, near. It was given by Boglers. So that can also be a question: who gave the technique of the vertical mattress? By Boglers, Boughlas. And this is done both for the anterior lamella and the posterior lamella, and the lid margin is brought together, and the an eversion is achieved, a pouting is achieved at the lid margin area. The anterior lamella is then closed in a fashion manner with using interrupted 6-0 silk. Care should be taken to close the lateral part of the canthus towards the end. So in this video, I had shown you how a direct closure is done, a vertical mattress, a canthotomy, a Tenzel's, and let's move on to the larger defects. When you have a defect which is more than half or 2/3 of the lid, entire length of the lid, we have for the upper lid the Cutler bed technique. It's also called as the bridge flap or a buckle handle technique. It is basically a full thickness advancement flap from the lower lid. So basically, this is the large lesion. Supposingly, this is the amount of defect that is created in the upper lid. So what would you do is, for covering this defect, you will take a full thickness flap. Full thickness includes the skin, muscle, and conjunctiva from the lower lid. And by preserving this tarsus, because I said tarsus is the cytoskeleton and is very important as a rigid structure for maintaining the adequate apposition of the lid to the globe. So this is not sacrificed, and that is also important again as far as the vascular arcade is concerned. And this entire flap is raised, and this is then passed underneath the bridge to fill in the defect superiorly. Again, layer by layer, conjunctiva to conjunctiva, and all the layers anterior to posterior. I'll show you this video of a cutlet where stage 1 done in a 2-week-old baby. So this was a upper lid coloma and an abortive cryptophthalmus, wherein now the marking is made for the lower lid around 5 mm away from the lid margin because we need to preserve the lower lid tarsus. A full thickness skin incision is made using a 15 number blade. Full thickness includes right from skin till the conjunctiva. The length of this defect would be equivalent to the defect present up superiorly. Two vertical incisions are then placed up till the fontanel depth. The flap is then taken across this bridge, underneath the bridge, and is brought close to the upper lid defect. And then you suture the layers one by one. The conjunctiva to conjunctiva using a ectomicril, the lower lid muscle to the upper lid, whatever tissue is left, if it all tarsus or to the LPS and orbicularis muscle, and the skin to the skin. So once that is done, towards the end, what we also do is we retract the lower lid bridge and then suture the cut end of the bridge from the to the lower lid flap, so that better aesthetic outcome for the lower lid also achieved. Now, the problem with cutlet based is that it is a stage procedure, as I had already said, and then you have a do a second surgery after 6 weeks. So this was this male in whom that large lesion was removed, and you have this flap shade from the lower lid going underneath this bridge. If you can very well see, it's underneath this bridge. So basically, this is the lower lid bridge, which has to be now taken care of. And the now for the second stage surgery, the bridge is retracted and the incision is marked according to the desired level of lid height, which is required for the upper lid. So basically, this is upside down. This is the upper lid, this is the lower lid, and the bridge is retracted inferiorly. And then the bridge flap is divided, taking into account that it should be divided in a convex down fashion because you would want some extra tissue medially, so that whenever contraction happens here, this would level up with whatever the rest of the limited margins are present, lid margins are present, as well as we need to divide it layer by layer, skin to conjunctiva slowly, taking more of conjunctiva into account so that this excess of conjunctiva can be sutured to the lid margin here, and thereby we have a smooth mucosal lining and not as keratinized skin rubbing against the cornea and causing microtrauma. So that's very important. So this was cutlet based stage 2. The stage 2 is generally done at an interval of about 6 to 8 weeks. In infants, because of the urgency, you can do it earlier at about 3 to 4 weeks. Coming to the next lid sharing procedure, use tarsoconjunctival flap. Herein, this is done for the lower lid defect. Tarsoconjunctival flap from the upper lid is mobilized to fill in the posterior lamellar defect. So this is just the posterior lamella, and for the anterior lamella, as I said, you can have the skin graft or an localized myocutaneous advancement flap. So this was this patient with a large BCC of the lower lid, wherein after removal you had a large defect that was created. So to fill in this gap, we raised tarsoconjunctival flap. So you invert the upper eyelid, mark an incision at the in the conjunctiva about 5 mm away from the lid margin, so as to preserve some amount of upper lid tarsus. The tarsus is good enough. You have 10 mm of tarsus, you can preserve 5 mm, use the 5 mm for the inferior lid. And then this dissection is carried down deep to the tarsus level, not beyond that. You dissect out the tarsus from the underlying LPS fibers. You also place two vertical incisions here. This is the two vertical incisions are placed like you do in cutlet bed, so that the flap can be now mobilized inferiorly. So you have this flap which is free from the underlying structure, overlying structures here, and this flap has been mobilized inferiorly. You have a tarsoconjunctival flap. Now the conjunctiva to conjunctiva is sutured and tarsus to tarsus is sutured. And over that, you can place a skin graft, a full thickness skin graft. In this case, this was the 6 weeks when the patient had come back again for the stage 2. Otherwise, you can also do a local myocutaneous advancement flap. Like in this case, we had this postoperative outcome after the stage 2 was done. So this was when you had a full thickness defect along with lid margin area involved. What is next is just a partial thickness defect where you have an interlamellar involvement only. So that you can, it's just a skin thing. So you can directly close primarily with or without undermining the surrounding tissue, skin to skin and muscle to muscle in layer. It could be dealt by a laissez-faire. So what's laissez-faire is an important question in exams. Healing by secondary intention or granulation formation. Fox and Beard were the first to describe it. There are only few indications where you do laissez-faire, so you should be knowing them by the tip of your fingers. Firstly, a relatively small middle canthal defect, it can be left to heal on its own. A superficial surgical defect like aberrations of the eyelid can be left to heal on their own. In poor surgical conditions, especially when the patient is not fit for GA, you can still leave it to heal on its own and help let the granulation tissue to come over a period of time. And especially in cases where you have taken out a tumor, but you're not sure if the entire tumor margin is cleared, you would not want to cover it with a flap or a graft. So in such cases, you can leave the tissue to heal by laissez-faire or a secondary intention healing, so that whenever there is a recurrence, you are able to detect it very well. And other methods of reconstruction include flaps and grafts when you have just an interlamellar defect. The advantage with flap is that it has its own blood supply. Therefore, you're not much doubtful about the bed. You're not worried much about the bed. It is cosmetically better because it is taken from a nearby surrounding skin. So it is more of a similar color, skin has similar skin texture, and also causes less contraction. The problem is because it has been shared from a nearby skin area, so you have a secondary scar formation there. So that is the problem with flap, which is an excuse me, which is an advantage in skin graft, wherein the graft is taken mostly from the retroauricular area. So you have the scar, but it is hidden. It's behind the auricles. But the problem with the grafts are they can be cosmetically poor because they are not from the same nearby surrounding skin. So they may discolor, they might have different color. Grafts do contract either primary or secondary. And then again, the grafts require good bed with good nutrition. So you always need to be careful about wherever you're placing grafts, and maybe not in the acute settings where you can use a full thickness grafts. So we should know about the stages of graft take. So what are they? They are plasmatic imbibition, inosculation, and revascularization. So what happens during plasmatic imbibition is during the first 2 days, wherein the graph starts drawing fluid from the host bed to the plasma, which is present in between them. At this stage, the graph appears to be cyanotic and edematous. Then you have the inoculation stage, wherein just progressive anastomosis of transected vessels starts happening, and the color slowly changes from cyanosis to lighter red color, pinkish color, and eventually you have the revascularization starting from the third day to the seventh day, wherein the capillary buds in the recipient bed invade the dermis to restore the normal graft circulation and appearance. So by now, you start having the graft to have a reddish pinkish color. Skin graft could be full thickness, could be split thickness. Full thickness graft means epidermis, dermis, and some amount of fat can be along with it. Split thickness is only a part of dermis along with the entire epidermis. So you don't have those important elements which helps in providing good cosmesis in cases with full thickness. So that is the advantage with full thickness. It is provides better cosmesis. Therefore, for face or any aesthetic area, full thickness graft is always preferred over split thickness graft unless there is extensive damage, there's a large defect, there's a large burn area. So this is when the split thickness comes into role, because for full thickness, the donor site has to be closed because you're removing the in toto of it. However, in split thickness, the donor site is just left behind and allowed to heal on its own with a subtle scar. I'll show you how a split thickness graft is taken. Both the grafts tend to contract. For full thickness graft, it is primary contraction more, and for split thickness graft, it is secondary contraction more. So what is primary contraction? You take out the graft contracts. So this is because of presence of some myofilaments, myofibrils within the graft. That is why it immediately contracts a full thickness graft. Split thickness graft contracts, but it contracts later on. So that's a secondary contracture for split thickness graft. As I said, full thickness graft is what is more preferable for the face and for the periocle area as well. So what is the ideal site for donor? So it is basically the contralateral upper eyelid skin, because that is a hidden area, and the skin is very similar to whatever in its thickness, in its texture, in its color to the damaged area skin. But in more or less cases, no one would allow to touch a normal eyelid and create a secondary scar there. So the most practical option is the retroauricular skin or the post-auricular skin. That creates a hidden scar, a supraclavicular skin, an inner arm or an inner thigh area. So this was a case of full thickness skin graft harvested from the retroauricular area. The defect size is measured in the eyelid, and you make ellipse over the retroauricular area. The pinna has been turned upside down, and this the size of this graph should incidence should be around 20-30% more. As I said, you'll have more of primary contractions. So you need to oversize the graph right now. So once that is done, a good amount of anesthetic agent is injected subcutaneously, and the graft is raised from the underlying bed. So you should try to pick less amount of subcutaneous fat, because eventually you need to debulk the fat. Why you need to debulk is the graft should not be very thick, because once you have a thick graft, you need to have a revascularization from the bed. So this would prevent any good revascularization. And at times you might have graft failures. So what are the other important methods of improvising the graphics? So one is debulking. This is again an important question. The second thing is you at times mesh up the graphs. You make small holes in the graft. Graft meshing is done so that any hematoma or seroma which is formed between the host bed and the graft can exit from those mesh or the button holes in the full thickness skin graft. Apart from that, what you also do is you do a thing called as quilting. So I hope everyone has seen a pillow with a central quilt present. So what we do is basically, if this is the graft, we take a full thickness bite from the graft. Full thickness means from the skin, we go posteriorly across the graft and then suture it to the bed and then come out. You will tie the vicryl sutures here using a 6 or 8 vicryl so that the graft gets attached to those areas. So with this quilting, we are also increasing chances of graft take, and there is less chances of any hematoma or seroma in between again collecting. So besides these three techniques, what we also do is we place a bolster over the graft. So this bolster is placed for about 5 days, and post which it is removed. So this is how you increase the chances of a graft take for a full thickness skin graft. So coming to split thickness graft, so where do you generally take a split thickness, harvest a split thickness graft from? Is from the inner thigh. So this was a patient wherein we had harvested the split thickness graft. It was usually the monthly slide that we harvested split thickness graft from. But these days we use a mechanical dermatome. This is a mechanical dermatome that I had harvested the split thickness graft for a patient for a contracted socket. So you'll see a small, thin layer of skin coming out from this area. This is the skin that has come out, and this is the pinkish bed that is left behind. So you don't need to close this bed. This will heal it on its own. So this was the graft that was obtained from there. In this case, we had done it for a contracted socket. So till now we were discussing about grafts. Now we'll go across to flaps. So skin flaps are composed of skin and subcutaneous tissue. They must have their own vascular pedicle. So basically, this is very important. How a flap differs from a graft. Flaps not need to be oversized because they tend not to shrink much, but they should not also be undersized because this would result in wound tension. That is the again a key rule to be followed, that the wound should never be under tension. They should again be along the resting skin tension lines whenever you are doing it. Also, supposingly this is the flap that you have harvested. So this is the base of the flap and this is the leading edge. So the width or the base should not be the length of the flap should not be 3 times more than the base of the flap. So generally we keep a ratio of 2:1. The length is to the base. This is the standard, but you can extend it to 3:1 and very rarely 4:1, but never more than that, because in such cases, you'll have a very long flap, you'll have a short base, because from the base is where the vascular supply is coming, and thereby it would result in necrosis of the flap, because this is from where the vascular supply is coming. If it's very small, it would lead to necrosis of the flap, and especially the distant flap, which will get necrosed. I told about the mnemonic for flaps. It is STAR: sliding flap, transposition flap, rotational flap, advancement flap, and then you can also remember the island flaps. So, starting with sliding flaps, I would not go to the details of flaps because it's difficult to explain without giving a hands-on demonstration. Sliding flap could be a simple or a modified ellipse flap. So supposedly you have a lesion here on the skin. Supposing this was not a defect. So what you do is for a sliding flap, you make an ellipse all around it and then dissect subcutaneously and then slide this to have a good closure. So that's a sliding flap. In advancement flap, what you do is supposedly this was the lesion, small lesion here. You make a rectangle all around it. This is for the lower lid especially. And then you advance tissue by creating vertical incision into this defect. So this is the flap that is red, and this will come and get attached, sutured here. So what would happen is towards the end you'll have dog ears. So this dog ears can be taken care of later. Also, primarily what you can do is you can make two triangles, small triangles here. So this would also help in removing the dog ears very well. Uh, uh, Other type of advancement flap is the YV-plasty. So YV-plasty is generally, you will get a question on BPS patients. In BPS patients, where there is a blepharophimosis, there is a horizontal as well as vertical shortening of the palpebral aperture. So we take care of the horizontal shortening by this YV-plasty. So basically, this is a Y made over near the middle canthal area. Supposedly, this is the right eye, and you have the at the middle canthal area, make a Y. So you cut open this Y, this converts into a V-shaped wound defect, and that is closed in a V-shaped manner. So you had this particular point here. Now that gets pulled and comes up here. So that means you have stretched the horizontal palpebral aperture and elongated it. So YV plasty generally tend to enlarge the is used generally tend to enlarge the areas, and VY plasty the other way around is generally used to shorten up the area. Then is the rotational flap, which could be a single, bilobe, or trilobe ones. We discussed about the standard tensils, semicircular rotational flap. I had already showed. It could also be rhomboid and glabid flap, which are taken from the forehead. We also have the transposition flap. The Z plasties is a very classical example. I'll show you how freakies and trapeze are done. So this is a case of a trapeze flap wherein you take you harvest the tissue from the this is the defect in the lower lid. You harvest the tissue from the flap from the upper lid area between the lid crease margin and the lid margin, so that gets hidden, so you take a skin flap, a micropenis flap from there, and then put it in the lower lid defective area. And freakies flap is similar. However, now the flap is raised from the eyebrow area, and that could be either used for the upper lid defect or for a lower lid antilaminar defect, a micropenis flap. By name, you should also know about a Mastardis cheek rotation flap. Basically, it is used when you have a low lid DCC or something, and then you create a very large defect. What is important is this is used for vertical large defects. Whenever you have a very large vertical defect, you cannot do a huge tarsocongenital flap. In these cases, a Mastardis cheek rotation flap is what comes into role. The flap is made by making a skin incision all along the lateral part of the eye, going all along the in semicircular fashion along the lateral part of the eyebrow, anterior to the triangle area. So this entire thing is raised anterior to the smash plane, keeping in the facial nerve intact. That is what you should know, that a Mastardis cheek rotation flap might lead to a facial palsy if not done very properly. And then this is rotated and closed with the posterior lamella. This is closed in place, and then posterior lamella graft is placed by MMG or mucous membrane graft. So I would just keep off this video where we had done a Mastardis graft, or maybe I can just show some parts of it. So basically, this was a defect, and this was the incision that was made. And you can see that this is the graph that has been the flap that has been raised. So this is the entire flap that was raised. So sorry. So this was a flap that was raised, and we are trying to pose it and then see where and how to place the graphs according to the defect that is present. Towards the end, a mucous membrane graph, you can see that was placed for the posterior lamella. So till now we were discussing about the lid, whether it's full thickness defect or a partial thickness defect, but not the lateral and middle canthal area. So coming to the lateral canthal area, whenever defect is present, why is it very important to repair the lateral canthal? Also because it would lead to loss of the lateral canthal contour, which is very important aesthetically, and also lead to shortening of the palpebral aperture horizontally. So what is very important in lateral canthal repair is the Wittnall's tubercle. Identification of the Wittnall's tubercle is very important. And I have already previously mentioned that the Wittnall's tubercle is present posterior to the orbital rim margin. So you need to put in the lateral canthal tendon, hitch it to the periorbital tissues relatively posterior to the periorbital rim. This is a small video showing the same. We have a 409 proline suture. So if you can appreciate that, I went deeper to the bony margin, bony rim here, came out from the periorbital tissue. This is a horizontal matrix that I would like to do, coming out through the canthal tendon, lateral canthal tendon. Again, going back in a horizontal matrix fashion, and then taking a deeper bite, through the posterior to the orbital rim. So once that is done and the switches are tight, you can see that the lateral canthal tendon has gone very well posteriorly and gives a very good contour. The anterior lamella then can be closed in layers by vicryl and subsequently skin to skin in an interrupted manner. For the middle canthal area, you have the canalicular injury, which is very common that you see. For canonical injury, what is very important is identification of the middle cut edge. So this is the middle cut edge. So that needs to be identified. So that is very difficult. So how can you identify a middle cut end edge? Either by direct observations, you can zoom in the microscope as much as possible and try looking for a small roundish cut end with an inside lining which is very smooth and appears to be glistening and whitish in nature. So that is one of the method. The other method is using a dilated fluorescent dye. So in this, what you do is you inject the fluorescent dye from the upper puncta, and some amount of it will definitely go to the NLD, but some amount of it will also regurgitate from the lower punctal area. So this regurgitated medial cut edge of the lower canalicus is the this is how you will identify the other end. The third technique is bubbling technique. So what you do is basically in this technique you pour some saline at the lacus lacrimis area, this area. Some saline is poured, and then again you inject now air bubble from the upper puncta. So once you inject air bubble, it will go through the common canalicular area and then try coming out from the middle cut and edge of the lower canalicus. So once it starts coming out from there, bubble will start. You will be able to appreciate bubbles in the saline that you have poured in there. The fourth manner is using a pigtail probe. I'll just show a video on that. So once that is done, once the middle cut and edge is identified, it's all simple. You need to place in this mini monoclinical stent right through this defect across the other middle cut and edge, and then let it stay inside the common clinical area for about 6 weeks period, and then it is removed. Meanwhile, the canalicular would very well get healed. So this was a 9-year-old boy with a right lower clavicle laceration, which had the patient had this history of fall and head to the table corner. So what is important is proper dilation of the upper lacrimal punctum and the lower lacrimal punctum, both of them, so that we can easily put in the probe. So this is the after dilation, adequate dilation of the leg. This is the pigtail probe that I was speaking about. So this is a typical curvature which follows the common canalicus of a human and then has a eyelet towards the leading edge. So basically what you need to do is once you have that, you need to insert it from the upper punctum, let it go along all the canaliculus and then the common canaliculus and then the lower canalicular area. So once that happens, what you would do in the rotatory fashion, it might start tending to come out through the middle cut and edge. So this is the pigtail probe which was already out. So this is the one that you are appreciating now. So this is the middle cut and edge. So it has come out from there. Now what we do is we again insert this pigtail probe through the lateral cut end of the lacerated canaliculus and come out through the lacrimal punctum. Once that is done, as I told, it has an eyelet towards the leading edge. A proline loaded with a mini monoclinical stent is passed through this eyelet. And we remove the probe now in a reverse fashion as we had inserted, bringing it back from the upper canaliculus and then the upper puncta. This pulls the mini monoca stent through the both the cut end edges and then inside the claviculus. And then you all need to do is just bring the close the cut end edges vertically in a vertical mattress fashion. And after 6 weeks, you remove the mini monocular canalicular stent. So this was this another child with a mini monocular stent placed. And this was at 6 months. It is a very good, very well placed lower lid defect area. Very good aesthetic outcome as well as the functional outcomes are very good. You don't see epiphora there. There's the tear meniscus height here is very normal. So that indicates that it was a good functional outcome as well. So coming to a few advances that we had done at our center, this was done by Dr. Neelam, lateral eyelid rotational flap, wherein when you have a very large defect for the upper eyelid, if you do a cutlet bed flap, what happens is you tend to lose because a cutlet bed flap would not lead to provision of cilia here. So what you do is basically you take care of that with the pentagon. You mobilize the lateral canthal tendon area. So basically what we are doing is we are sharing the lateral canthal tendon along with the hair bearing area of the lower lid. So that helps in formation of cilia all along the upper lid, and then you have a good cilia in the upper lid. Cilia presence in the upper lid is very important again because that is what covers the lower lid. It's slightly placed up and down so that cilias are very well seen. Another recent publication from our center is an auricular skin cartilage sandwich graft. You all must be now well aware that I told that both the lamella cannot be grafts. Either it could be an anterior lamella, anterior graft, posterior flap, or an anterior flap and a posterior graph. But in this paper, what we had done is we had taken a full thickness auricular skin cartilage. So we had a skin and as well as the cartilage which was harvested. We made a pocket in between the skin and cartilage and sandwiched orbicularis embedded inside them, so that it could supply very well to the superiorly to the skin and inferiorly to the below it to the cartilage. And that's how we tried to keep the vascularization of the grafts in position. So this was one of the patients who had the defect is not very well seen here. It was had a very large effect, and this was a good outcome after that. So towards the end, I have this iWiki article published by me and my colleagues, for which I had also received previously on eyelid reconstruction, a recognition by the American Academy of Ophthalmology. And thank you so much. I hope I was able to solve few of your small doubts.
Excellent presentation, Sahil. Very
I hope it was
comprehensive.
not too exhaustive because yeah, 30 to 40 minute lecture drains you out.
No, it was kind of rapid fire, but it was very detailed, and I think you covered all the topics that a postgraduate and a DNB student need to know. When they are answering questions in the exam. Do we have any questions from the audience?
Mr. Sunil, can we have the questions if there are any?
So while he's pulling out the questions, I would like to add a couple of things. So, uh, the lid margin reconstruction is very commonly asked in the exam because it is suppose that you are at the postgraduate level, you should know how to reconstruct the eyelid because that is common principle to tumors, trauma, and everything. So when you like you said that you pass a vertical mattress suture and you go 3 millimeter from one edge, 3 millimeter from one edge, and then come out 3 millimeter opposite, and 1 1. So it is 3 1 1 3. If I were to reconstruct an upper lid where the tarsal height is more, I usually use or one can use 5 3 3 5 rule. So you take a bite
Right,
5 from the cut end because the tarsal height is more, so you want a good support on the eyelid, and the
right,
cosmetic outcome is also good. So that is one thing that I would add to your presentation. And also, when you are reconstructing lid margin defects, you need not suture the conjunctiva. So once you oppose the lid margin with the pouting, like you explained, that the edges need to be everted or pouted, then you can just close the orbicularis and the tarsus and the skin, and you need not suture the conjunctiva. So conjunctiva is not one of the layers that is sutured. Also, something that you beautifully highlighted and is always asked in the exam is that when you are reconstructing with the help of a skin graft, what size of the graft will you take? It should be 30% more than the size of the defect in the eyelid because primary contracture does happen, and then you will fall short of the defect. So this was asked to me in the exam actually, that आप कितना बड़ा size का graft लोगे? So that should be a prompt answer of that. It should be 30% larger, so you measure accordingly, and then so that's my otherwise there's not much to add. You covered
right.
everything.
Again, flaps I thought of covering more in details, but then not showing the flaps and just doing telling it theoretically doesn't make more of a difference. So I just thought of taking the technique, taking out the technical aspect, just giving the theory to them.
If you did show a couple of named flaps. So if you know 2 3 named flaps and
That is good enough for
how
exams.
they are harvested even diagrammatically, I think that would be
Good
enough,
enough.
for the exam point of view. You don't need
True.
not to waste too much energy going into the details. So I think that you did justice to your topic very nicely and did not go in details which are not required at postgraduate level.
Right. Thank you so much.
Dr. Pranita, do we have any questions?
Yes, we have one question, sir. One of the student is asking, are there any contraindications to skin grafts or skin flaps, wherein there is an indication you have a large defect, but there are contraindications to skin graft or skin flaps?
So basically, in acute conditions, in acute settings, we generally do not tend to do grafts. Why? Because acute, especially when you have a burn patient or you have a non-nutritious bed, it could be infected bed. So this might lead to necrosis of the graft. So that is one area, as well as the flap should not be done in such conditions. For that, again, if you have a full thickness defect of the upper eyelid and the entire cornea is exposed, if we had another paper where we just took the postal lamellas, brought them close together, and then covered the cornea underneath. So that is one thing that you can get away with so as to prevent an exposure keratopathy. But yes, if you have a necrosed or a infected bed, full thickness grafts or even partial thickness grafts might not survive very well. What's your take on this, Dr. Puneet?
agree. Any condition in which you feel that your entire surgical effort is going to go waste. So more specifically, infective conditions where you would want the wound to settle, or more specifically, burns, like you said. So these would be the two most important things. The third could be, you can state as a contraindication is you highlighted in one of your slides that if you're waiting for results on the biopsy or if you're not sure about tumor recurrence, then also, you would wait out
You
and let it
avoid it.
heal. There's no rush in reconstructing, especially if you're dealing with bigger issues at hand.
So again, one thing what I learned from dermatosurgeons was that the face heals very well. It's so vascular. Most of the areas, I recently did a glabular flap and there was a triangular tissue left out here. I just made it to stay back that when it granulated very well. So that is what I learned from dermatosurgeons here at Ames.
Right. So that way, oculoplasty surgeons are blessed because eyelids, they do really heal very well. If you just oppose the anatomical structures the way they are supposed to be, they're very forgiving, and all the
I
credit goes to us.
So it's just a puzzle. Whenever I go there, I see a very large defect, but then at the end, what I realize is that all the tissues are still there, Sahil, and then there is no actual defect which is present. You just need to place the tissues layer by layer, and things will be taken care of.
I hope that answers the
Yes, I
the
think
participant's
absolutely.
question.
And any difference for patients who have had radiotherapy? In such patients, would you like to do grafts and flaps?
Again, yes, wherever required, you may do some partial skin grafts, but again, it's difficult to say whether a full thickness graft would survive or not, especially in the immediate period of post-RT where you'll have a lot of absence of vascularity. So in those cases, the grafts, full thickness grafts would tend to necrose away. So in such cases, split thickness graft is what is advised.
So I think we have had a wonderful class on lid reconstruction with so many surgical videos, diagrams, diagrammatic representation. It was, I think Dr. Sahil has done a wonderful job
Thank you
highlighting
so much,
the
ma'am.
important points. So with that, we come to an end of this class, and our next class will be on the 2nd of September. That will be 2nd on September that Dr. Pallavi Singh will be taking on ptosis, and surgical videos will be highlighted in that. So looking forward to having all these students along with us here in the DOS Postgraduate Education Program. And thank you, Dr. Sahil and Dr. Puneet, for joining in for the class. And good night.
Thank you so much, ma'am. Thank you, everyone. Thank you, Punit sir.
Thank you, Sahil. Good night, everyone. Good night.
Good night.
Views. How many views did we have today?